I would be asking you very specifically, out of or according to your personal experience as well as the information trickling in, that what percentage of patients are getting into shock, a septic shock, and whether we should keep the patient dry, because you said some of the patients are getting into AKI also, and what is the choice of vasopressors? Should we follow the SSC guidelines on this, or do you have the NHS have something else to say?
Shock is not a major problem at all. Shock often is associated uh, with the sedation that the patients might be on, because of some of them need quite deep sedation for the paralysis, neuromuscular blockade that you have to keep them on. So it's not a significant issue with these patients. And obviously, if a very small number of people go into cardiomyopathy, etc., that's a cardiogenic shock, and you have to treat them as such. But otherwise, we are just using noradrenaline if we have to. It's not a huge problem so far. Fluid-wise, we are keeping them dry, and we have found a benefit of that. One caveat is that if one wants to make them dry at the very outset, say a patient comes in and they're in a significant respiratory failure, you ventilate them, you intubate them, and they're on ventilator, day one. I think there is a problem in trying to dry them up very quickly, because they are already a bit dry and you are drying them up more, and they are in the initial physiological instability, and you might drive them actively into a bad renal failure if that were to happen. If possible at all, it might be better to wait for about 24 hours to start drying them up, and dry at that point after 24 to 48 hours, dry them hard. So we certainly have used fusamide infusions at a fairly high dose to achieve a fairly good bit of negative balance without then losing too much renal function. And we have seen that has worked in some of our patients, and that's something we've heard from others as well. So not maybe drying up too early, but obviously these patients are not in shock. You don't need to give them too much fluid either. They just need to be neutral for the first 24, 48 hours, and as soon as it's safe, start drying them up. That's the strategy we are taking, and we have seen that working as well. And fluid-wise, normal crystalloid if we have to, but usually they're just on their feed and other drugs, and that's enough. No extra fluid, obviously.
No extra fluid required. Yeah, thank you on this part. I forgot to ask you certain one thing, that are there any prognosticate markers in terms of the progression of disease, or in terms of any biomarkers like interleukins, ferritins, or any other? Are you using any prognostication markers?
At the moment, this is a problem that not every center is using the same set of parameters for, and not in the same way. And maybe it's an opportunity where in a country or in a setup where the disease has not really gone in yet in a big way, it's an opportunity to set up a widespread guideline as to how every hospital do these tests. Otherwise, there is no way you are going to know which one is a bad prognostic marker, which one is not. Ferritin has been described, D-dimer has been described, but all of them are in small case series, 100 to 200 case series. And in anecdotally speaking, so far, we, as we have said, we in the UK are in the first kind of 2 weeks of the outbreak in terms of critical care admission. And what we have seen is something interesting. Ferritin is always high. Ferritin is in the region of 1500-1600, as I said. But in some patients who have been poorly, in them ferritin might be totally normal. And I don't know how to explain this. We don't have enough numbers, and we need to see how it is done. So I think what needs to really happen, and this is an opportunity for India as well, is that we set up a protocol of certain tests at a very rigid interval. Say, for example, in our hospital, we are we have talked about, and we have started to some extent in the recent days, that you do certain tests. You don't do ferritin for everyone. Say day one, you do PCT, ferritin, CRP, LDH, D-dimer, troponin on top of your normal blood tests. And then all the inflammatory parameters, ferritin, CRP, and PCT, can be done every other day, alternate days. And if every hospital does the same, and if that data is collected, then only you can use them as your prognostic markers eventually. Unless you can build up a big baseline data set and you are following those patients up and see which patient gets better and who don't survive, there is no way you are going to make a proper prognostic.
So,